So today we will discuss drugs used for constipation. This is mainly a fact-based topic, so you have to remember a lot of facts. But some concepts are there which I will make you understand better. So constipation is defined as, how is constipation defined? Constipation is defined as decrease in frequency or liquidity of stools compared to normal pattern in an individual. So constipation is defined as decrease in frequency. Either there is decrease in frequency of stools, the number of stools, or the fluidity of stools, the liquidity of stools, as compared to the normal pattern in an individual. Now, drugs for constipation are one of the most overprescribed drugs. Self-prescription is also a problem with these drugs. They are commonly self-prescribed. Now, a large proportion of constipation is amenable to lifestyle modification. So, lifestyle modification should be the first step to treat constipation. What are the lifestyle modifications we need? First is high fiber diet. Second is adequate fluid intake. High fiber diet can be achieved by increasing the intake of fruits and vegetables. Adequate fluid intake by increasing the water intake. Regular exercise. Regular exercise promotes bowel movements and heeding of nature calls. So, one must go for defecation when there is urge. They should not try to control it. In cases of acute constipation, acute intestinal obstruction should be ruled out prior to prescribing drugs. In case of acute constipation, acute intestinal obstruction should be ruled out prior to prescribing drugs, because acute intestinal obstruction often needs surgical management, so it should be ruled out in cases of acute constipation by thorough history and general examination and abdominal examination, and maybe some investigations. Now, drugs for constipation are called laxatives or purgatives. They increase bowel or colonic evacuation. So drugs for constipation are laxative or purgatives. They increase bowel evacuation. Now, there are two categories of drugs, laxatives and purgatives. The terms are often used interchangeably, but there is a difference between the two. So laxatives are mild, slow-acting drugs. while purgatives are strong, fast-acting drugs. Laxatives cause egestion of formed stools. As they are mild drugs, they cause egestion of formed stools, while purgatives cause egestion of watery or loose stools. Laxatives are also known as aperients. While purgatives are also known as cathartics. Now there are some differences in mechanism of action of laxatives and purgatives. So we will discuss those mechanisms. Few mechanisms we will discuss. So purgatives, they increase propulsive activity. This is their primary action. They increase propulsive activity, allowing less time for absorption of salt and water. They have hydrophilic or osmotic action. Leading to water retention as well as retention of electrolytes in intestinal lumen. So water content and electrolyte contents of intestine increase. They increase the intestinal transit, fasten the intestinal transit, leading to decreased absorption of sodium and electrolytes and water. So decrease absorption of electrolytes and water. Now laxatives, they modify the fluid dynamics of the mucosal cell Now some mechanism by which they increase the bulk of stool is they increase the fluid accumulation in gut lumen. How? By inhibiting sodium potassium ATPase pump in villus cells. Which leads to reduced water and electrolyte absorption. So they inhibit sodium potassium ATPase pump of villus cells that leads to reduced water and electrolyte absorption. They stimulate adenyl cyclase activity in crypt cells. What they do? They stimulate adenyl cyclase activity in crypt cells, leading to water and electrolyte secretion. They increase prostaglandin synthesis in mucosa, leading to increased secretion. Increased prostaglandin synthesis in mucosa. Increase nitric oxide synthesis leading to increased secretion. Inhibit non-propulsive contractions in colon. Then structural injury to absorbing intestinal mucosal cells. So laxatives act by one or more of these mechanisms. So now we have understood the differences in mechanism of action of laxative and purgative. Purgative increase propulsive activity. They have hydrophilic or osmotic action and increase intestinal transit. While laxatives modify the fluid dynamics of mucosal cells through one or more of mechanisms such as inhibition of sodium potassium ATPase of villus cell, stimulate adenyl cyclase activity in crypt cell, increase prostaglandin synthesis in mucosa, increase nitric oxide synthesis, and structural injury to absorbing intestinal mucosal cells. Now coming to classification. So these laxatives and purgatives are classified according to their mechanism of action. However, sometimes they may act through multiple mechanism of action. So the first laxative we will discuss is bulk forming laxative. They are also known as dietary fibers. Now they could be plant fibers, such as methyl cellulose, bran, husk, psyllium, isfagula, or they could be synthetic fibers, such as polycarbophyll. Next are stool softening agents or stool surfactant agents. Stool surfactant agents or stool softeners. Examples are docosate, glycerine, and mineral oil. So stool surfactant agents or stool softeners such as docosate, glycerin, mineral oil. The third ones are osmotic laxatives. In that, the first category is magnesium salts. In that, we have magnesium sulfate, magnesium hydroxide, which is also known as milk of magnesia, and magnesium citrate. Magnesium hydroxide is also known as milk of magnesia. Next are sodium salts, such as sodium sulfate, sodium phosphate, sodium sulfate is also known as Glauber salt. Sodium sulfate, which is also known as Glauber salt, sodium phosphate, and sodium potassium tartrate. Which is also known as Rochelle salt. Then among osmotic laxatives are non-absorbable sugars and alcohols. Such as lactulose, mannitol, sorbitol, and lactitol. The last one is balanced polyethylene glycol. Balanced polyethylene glycol. The next category of laxatives is stimulant laxatives. That the first one is anthraquinones, such as aloe, senna, cascara, the next ones are diphenyl methanes, such as bisacodyl, sodium picosulfate, and phenolphthalein. This phenolphthalein is banned due to risk of carcinogenicity. The last ones are oils. Last one among stimulant laxative are oils, which there is castor oil. So among stimulant laxatives we have anthraquinones. Anthraquinones are aloe, senna, and cascara. We have diphenyl methane. In that there is bisacodyl, sodium picosulfate, and phenolphthalein. We have oils such as castor oil. Now the next category of drug is 5-HT4 agonist. And the name of the drug is prucalopride. We have discussed this drug in prokinetics, so I want you to refer to that section, as some of the prokinetic agents are also used in constipation. So this is one example. chloride secretion activators. Sixth is chloride secretion activators. The drugs are lubiprostone, linaclotide, plicanatide. Seventh is opioid receptor antagonists. The drugs are nalmefene, naloxegol, methyl naltrexone bromide, and albumin. So among opioid receptor antagonists, the drugs are nalmefene, naloxegol, methyl naltrexone bromide, and albumin. Now let's discuss bulk forming laxatives, which are also known as dietary fibers. So they are indigestible hydrophilic colloids. Indigestible means they are not digested. So they are made up of indigestible carbohydrates such as cellulose, lignin, and pectin. Hydrophilic means they attract water. So examples we will discuss: plant fibers, methyl cellulose, bran, husk, psyllium, isfagula. Isfagula is also known as isabgol. Synthetic fibers, polycarbophil. So what is their mechanism of action? They go in intestine, and intestine they absorb water. So water is absorbed and they form a bulky emollient gel. And what happens? They distend the colon. So colon gets distended and there is stimulation of peristalsis. So I'll describe the mechanism in a flowchart. They go in intestine, absorb water, form a bulky emollient gel, distend colon, increase spontaneous muscle contraction, and promote peristalsis. They have a prebiotic action also, and they stimulate the growth of intestinal flora. They are slow and mild acting drugs, and effect takes 3 to 4 days to come. Slow and mild acting. Effect takes 3 to 4 days to come. They are one of the commonly prescribed drugs for constipation. Now they are the drug of choice for functional constipation. The treatment of choice for functional constipation is lifestyle modification. But if that doesn't work, we give bulk forming laxatives. So they are the drug of choice for functional constipation. Predominant irritable bowel syndrome. They are also drug of choice for constipation, predominant irritable bowel syndrome. They improve stool consistency in patients with colostomy. Now, what are the adverse effects? They are unpalatable. They cause flatulence or bloating. Now, precautions. These preparations must be taken with water or they may cause obstruction. So first precaution is they must be taken with water. And they should be used cautiously in immobile patients. Because there is potential of causing intestinal obstruction. When a person is mobile, there are more GI movements which relieves constipation. So in immobile patients, there is risk of intestinal obstruction. So they should be used cautiously with monitoring. They are contraindicated in GIT ulcers. As they distend the GIT, they may cause perforation, GIT adhesions, megacolon. They may cause further aggravation of megacolon as they distend the bowel. In megacolon, bowel is already distended. They may cause GIT infection as they stimulate the intestinal flora. Now, stool surfactant agents. which are also known as stool softeners. The first one is docosate, which is also known as DOS. Full form is dioctyl sodium sulfosuccinate. It is an anionic detergent. Docosate is an anionic detergent. Next is glycerin suppository. Docosate can be given orally as well as enema. Glycerin suppository, mineral oil, and liquid paraffin. Mineral oil and liquid paraffin are not used. They are banned drugs. Mineral oil and liquid paraffin have been banned because they may be absorbed into lymph and may lead to lymphoid hyperplasia. They may also cause foreign body granuloma. There is risk of aspiration, which may lead to severe lipid pneumonitis. Now, what is their mechanism of action? They are oily substances which or have detergent action. They soften stool material. Permitting water and lipids to penetrate. They soften the stool material so that water and lipids can penetrate the stool. And thus they increase this softness of stool. Docosate is used when straining at stools must be avoided. So docosate is used when straining at stools must be avoided. Example of some conditions where straining at stools must be avoided are cardiovascular diseases, pregnancy, etc. Pregnancy is a physiological condition where one must avoid straining at stools. Now, docosate is not to be used for long term as there is risk of tachyphylaxis. Tachyphylaxis is rapid development of tolerance, and tolerance is decreased effectiveness of a drug with repeated use. It should not be used for long term as there is risk of development of tachyphylaxis. Now, what are the side effects? Side effects are abdominal cramps, abdominal pain, hepatotoxicity on long term use. The contraindications are intestinal obstruction. So, contraindication, intestinal obstruction, and they are not to be used concomitantly with, so docosate is not to be used concomitantly with mineral oil or paraffin. Now we will discuss osmotic laxatives. So we have discussed bulk forming laxatives. Now we will discuss osmotic laxatives. Now how they act? Suppose they draw water into the intestine and they increase osmotic pressure, increase fluidity of stools, increase osmotic pressure, and thus lead to peristalsis. So these osmotic laxatives are soluble but non-absorbable compounds. They draw water into intestine increase fluidity of stools, increase osmotic pressure, and stimulate peristalsis. Now the first class of drug is magnesium salts. Among the osmotic laxatives, the first class of drug is magnesium salts. Can be magnesium sulfate, magnesium hydroxide, which is also known as milk of magnesia, magnesium hydroxide is also used as an antacid, magnesium citrate. They are used for treatment of acute constipation. They increase cholecystokinin and thus increase motility. They are contraindicated in renal failure as there is risk of hypermagnesemia, contraindicated in intestinal obstruction, and their side effect is electrolyte imbalance. Now the second one are sodium salts. In that there is sodium sulfate, sodium sulfate is also known as Glauber salt. There is sodium phosphate, and sodium potassium tartrate. Sodium potassium tartrate is also known as Rochelle salt. They are the fastest acting laxative. Act in 1 to 3 hours. They are also known as saline purgatives. They are used in acute constipation. So uses are acute constipation, in poisoning of drugs. Suppose there is poisoning of an irritant drug, they can be excreted out, and in helminthic infections after the use of anti-helminthic drug, if we want to wash out the dead worms, then these drugs are used. They are contraindicated in intestinal obstruction. So these drugs are contraindicated in intestinal obstruction. They are also contraindicated in CHF, hypertension, and other sodium retention states. So why they are contraindicated in CHF and hypertension? Because they present the body with increased sodium load, and this can lead to retention of water. So they can aggravate CHF, that is congestive heart failure, and hypertension. Now non-absorbable sugars and alcohols. Examples are lactulose, mannitol, sorbitol, lactitol. Lactulose, mannitol, sorbitol, lactilol. So what is their mechanism of action? They are broken down to small fatty acids by GIT bacteria in colon. So lactulose is broken down to lactic acid, formic acid, and acetic acid. So these acidic contents increase osmotic pressure, and they stimulate the peristalsis. Now, this lactulose is the drug of choice in hepatic encephalopathy. Lactitol can also be used in hepatic encephalopathy. So we can use lactitol also. The drug of choice is lactulose. However, lactitol has better palatability and patient acceptability compared to lactulose. Now these agents cause lactulose and lactylol. They cause reduction of blood ammonia by 25 to 50%. Have Now these agents have acidic breakdown components. We have discussed that already, that acids are formed when they are broken down by bacteria. They have acidic breakdown components. So there is increase in acidity of colon. So this H plus is given to ammonia. So NH3 plus H plus and ammonium ion is formed in colon. And this ammonium, being ionic, being water soluble, cannot cross the membrane and is excreted out. So we'll discuss via a diagram. Suppose this is the liver and this is the colon. So normally what happens to ammonia? It goes to liver and it is converted to urea, which is a non-toxic substance. But in patients with hepatic failure, this pathway is not working. So there is no conversion of ammonia to urea. So there is excess of ammonia, which crosses the brain and leads to convulsions. This is known as hepatic encephalopathy. So what happens when we give lactulose? Suppose we have given lactulose. So there are when bacteria acts, acidic contents are produced. These acidic contents can give their H plus to ammonia, and this ammonia gets converted to ammonium ion, NH4 plus. And this ammonium, being ionic and being water soluble, cannot cross this GI membrane and thus is excreted out. So this cannot cross and is excreted out. Now the next one is balanced polyethylene glycol. So this is used for complete colon clearing before gastrointestinal endoscopic procedures. So prior to endoscopic procedures for colon clearing, this drug is used. Now it is a balanced isotonic solution. And what does this solution contains? It contains polyethylene glycol, sodium sulfate, sodium chloride, sodium bicarbonate, and potassium chloride. Now it does not produce significant cramps or flatters, so that is its advantage. It does not produce significant cramps or flatters. Now the next one we have is stimulant, which is also known as irritant laxatives. So the next one we have is stimulant or irritant laxatives. Now how do they act? They stimulate the intestinal epithelial or smooth muscle cells. So they stimulate the intestinal epithelial or smooth muscle cells, and thus they increase the peristalsis. So I'll write in a flowchart: stimulate epithelial cells or smooth muscle cells of GIT, activate myenteric neurons, myenteric neurons are the neurons that supply the smooth muscle of GIT, increase active muscle contraction, stimulate peristalsis, and can lead to spastic colon. Now these are strong drugs, so they should be given in low doses. So they should be given in low doses. They are used in short term for acute evacuation of bowel. For example, preparation of bowel prior to abdominal X-ray, USG, or surgery. Preparation of bowel prior to abdominal X-ray, abdominal USG, or surgery. Now, what are their contraindications? First, these drugs should not be used for long term. So they are not to be used for long term, as they are habit forming and can lead to abuse. So they are not to be used for long term. So you have to counsel the patient that these drugs have to be taken only for this required period. Now they are contraindicated in irritable bowel syndrome, can aggravate the spastic colon. They are contraindicated in pregnancy, as they stimulate uterine contractions and can cause abortion. They are contraindicated in intestinal obstruction. Side effect of these drugs are hypokalemia. Side effect is hypokalemia and reduced tone of colon. So what are the drugs? The various drugs we have are, first we have anthraquinone. In anthraquinone, we have aloe, senna, and cascara. Yellow senna and cascara. Now the side effect of these drugs is they can cause melanosis coli, pigmentation of colonic mucosa on long-term use. So they are not used for long term. Now they can cause rash and fixed drug eruption. Now diphenylmethane. The drugs are bisacodyl, sodium picosulfate, and phenolphthalein. This phenolphthalein is a banned drug as it increases risk of colon cancer. So phenolphthalein is banned, it is not used anymore. It is carcinogenic. It can increase risk of colon cancer. Now bisacodyl can lead to allergic reactions such as rash, Stevens-Johnson syndrome, etc. Stevens-Johnson syndrome is a very severe allergic reaction where there is peeling of skin. So around 30% of skin is peeled off or more than that. Now among oils, there can be castor oil, which is obtained from the plant Ricinus communis, but this castor oil is not used anymore. So among these stimulant or irritant, phenolphthalein is banned, castor oil is not used. Now the next class of drug is 5-HT4 agonist, and the drug which we use for constipation is prucalopride. It is used for resistant idiopathic constipation. First we give bulk forming laxatives. If there is no response, prucalopride can be used. These drugs are always to be used with lifestyle modification. Now how prucalopride is different from other 5-HT4 agonist which we have discussed in prokinetics. Prucalopride does not cause QT prolongation. Now the next category of drugs which we will discuss are chloride channel activators or chloride secretion activators. So the next category of drug is chloride secretion activators. The first drug we have is lubiprostone. As there is prost in here, it is a prostaglandin E1 analog. It is a prostaglandin E1 analog. It stimulates type 2 chloride channels in small intestine. binds to EP4 receptors on intestinal epithelial cells and activates adenylyl cyclase, increases cyclic AMP, and thus increases chloride secretion. Now it is a category C drug. When this drug was given to juvenile mice, there was increased mortality. Category C drugs means there are categories of safety of drug in pregnancy. So in category C, in animal models, some teratogenic effects have been found. So these drugs are avoided in pregnancy. They are approved for use in one, chronic constipation, two, constipation predominant irritable bowel syndrome, side effect of these drugs is nausea due to delayed gastric emptying. Now the other two drugs among chloride secretion activators are lenaclotide, and plicanatide. They stimulate guanylyl cyclase C on luminal surface. Increase cyclic GMP. Activation of cystic fibrosis transmembrane regulator. It is a type of chloride channel, and there is increased chloride secretion. It is approved for use in chronic constipation, and constipation predominant irritable bowel syndrome. So irritable bowel syndrome can be either diarrhea predominant or constipation predominant. So it is used in constipation predominant irritable bowel syndrome. Most common side effect is diarrhea. It is contraindicated in pediatric patients. It's not safe in children. Now the next category of drugs that we will discuss is opioid receptor antagonists. The drugs are nalmefene, naloxegol, methyl naltrexone bromide, and albumin. first three. All these drugs do not cross blood-brain barrier and inhibit peripheral mu opioid receptors. They do not cross all these drugs do not cross blood-brain barrier and they inhibit peripheral mu opioid receptors without impacting analgesic effects within patients. So what happens many a times for chronic pain, patients are given opioid analgesic. So as a side effect, they get constipation. Now for the treatment of this constipation, these first three drugs can be used. These first three drugs can be used for treatment of opioid induced constipation. So they do not hamper the analgesic effects. They just inhibit peripheral mu opioid receptors. So they block mu opioid receptors only in periphery. Now they are metabolized by CYP3A4 and enzyme inhibitors can increase their concentration while enzyme inducers can reduce their concentration. They are metabolized by CYP3A4. Side effect is nausea, abdominal pain and diarrhea. Now this alvimopin it is also a mu opioid receptor antagonist. So M for mu you can remember, OP for opioid and AN for antagonist. But it is approved only for short-term use as it may cause cardiovascular toxicity. It is used only for short-term and where in post-operative paralytic ileus. Now indications of laxatives. So now we will discuss overall indications of laxatives. So the first one is functional constipation. So in functional constipation, the first treatment that we give is lifestyle modification, and that is the treatment of choice. By lifestyle modification, we mean high fiber diet, increased fluid intake, regular exercise, heeding to nature's call. If this is not effective, then we can add drugs. So there are two types of functional constipation. Either there can be a spastic constipation. The colon is in spasm. So for that, ispagula may be given. Bulk forming laxatives may be given, especially spagula. Stimulant laxatives are contraindicated over here as they may cause perforation. Now the second type may be atonic constipation. For atonic constipation, bulk forming or osmotic laxatives are prescribed. Now we may need laxatives in bedridden patients. such as myocardial infarction, stroke, fractures in post-operative cases. So to prevent constipation, we use bulk forming laxatives. While to treat constipation, we use soap water or glycerine enema. The third indication can be to avoid straining at stools. Such as in cases of hernia, cardiovascular diseases, eye surgery, piles, fissure, anal surgery, bulk forming laxatives are used. Now the fourth indication may be constipation, predominant irritable bowel syndrome. So the first thing we do is lifestyle modification. If that doesn't work, we give bulk forming laxatives. And if there is no relief to that, we can add citalopram. You can give levetiracetam and other fluoride channel activators, fluoride secretion activators. Now the next is preparation of bowel before surgery, colonoscopy, abdominal X-ray. Saline purgatives or bisacodyl and senna can be used. After certain antihelminthics, so saline purgative or senna may be used. We can use saline purgative or senna. Sixth, food or drug poisoning, saline purgatives are used. So these are various indications of laxatives. Now there is something called as purgative abuse. So purgatives or laxatives are one of the most commonly self-prescribed drugs. And some people have a habit of taking the purgatives. They are obsessed with using purgatives regularly. Once the purgative intake starts occurring, the breaking of this habit is very difficult. It is very difficult to break this habit. What are the drawbacks? What problems can occur to the patient? First, fluid and electrolyte imbalance. So patient may need hospitalization also. One, to correct the fluid and electrolyte imbalance, and second, to monitor them so that they cannot take the purgative. and this habit can be broken. Dehydration can result. Hypokalemia is especially problematic among electrolyte imbalance. Then there can be steatorrhea, loss of fat in stools, malabsorption syndrome, protein losing enteropathy. Patient is unable to absorb proteins. Spastic colitis, inflammation of colon. Especially use of stimulant purgatives leads to spastic colitis. So that is all for the day. I hope you had a great learning experience. Thank you and have a nice day. I've started my Telegram channel Dr. Swapnil Rai Pharmacology, where I post PDF and other updates. Kindly join this channel. Thank you.